All right. Well, I'm Maggie Dolan. I am a physical therapist at Craig Hospital in Colorado. I've worked there for coming up on 11 years, both in the acute inpatient rehabilitation setting as well as outpatient setting and our seating and positioning clinic.
I'm Janelle Jones. I've been at Craig for 10 years. Also worked both inpatient spinal cord injury and patient brain injury, and then I'm currently in the outpatient spinal cord injury department.
All right. And today we are going to present on manual wheelchair configuration and hemi-propulsion and the effects of wheelchair characteristics. This information presented today is based off of a pilot study that we recently concluded at Craig Hospital. We have no conflicts to be disclosed. And then kind of going into the background and the study origination. So Craig Hospital in Colorado specializes in both acute care as well as ongoing follow-up care for individuals with both spinal cord injury and traumatic brain injury. And a number of our patients with brain injuries are requiring a manual wheelchair for mobility, both within their home and community environment. And we know that based off of their motor and their sensory and their cognitive impairments, they often use different types of propulsion for manual wheelchair mobility, including hemi-propulsion, defined as using unilateral upper and or lower extremity for those propulsion characteristics, and that this type of propulsion is inherently more difficult than upper extremity propulsion, but really there's a gap in the literature on how a frame and configuration of a wheelchair affects hemi-propulsion. And we really have to give a lot of credit of this study to Angela Regier, who was previously an OT as well as our wheelchair clinic supervisor at Craig, and when working on a course for wheeled mobility with acquired brain injury. Yeah. She really noted the lack of evidence in this area in literature and came to our research director to kind of propose this as an option for gaining evidence. So really this project was really developed to inform clinical practice on the functional effects of axle position as well as frame design in hemi-propulsion, and then hopefully provide evidence on differences that may promote funding in the future. So we're going to kind of go through some background information and categorize what was utilized in this study. So we were looking at the difference between a high strength lightweight wheelchair K4, which we know from a characteristic standpoint has a weight of less than 35 pounds. Your seat height has some limitations in 17 to 21 inches, and then also limited options for seat width and depth in comparison to an ultra lightweight or a K5 wheelchair, going to be lighter weight, and then those customizable options for your floor to seat height, your seat width and depth, and then additionally seat back angles, camber, and then one of the most important things that we'll evaluate throughout the study is that adjustable axle. So regarding that adjustable axle, we know that a axle that's in a more rearward position increases the stability of the chair, whereas a axle in a more forward position is going to make the chair lighter weight to push. And this has been heavily studied in upper extremity propulsion, in someone's functional ability as well as the biomechanics of their shoulder, but it hasn't been studied for the impact of axle position during hemi-propulsion. Next, we'll go into frame design. So in this study, we utilized two different types of ultra lightweight frames, including a folding frame. So as you know, this has that cross brace design, easy to fold. Generally is something we think about using for individuals who are either performing like standing or weight bearing transfers or are using their lower extremities for propulsion based on those either flip up foot plates and or swing away leg rests. Contrary to this is going to be your rigid frame chair, which doesn't have that cross brace. It's going to be more less flex in the frame, which can improve the efficiency of propulsion in that. And to note for this study that there are options in the rigid frame for both flip up or flip back style foot plates in order to allow that lower extremity access to the floor.
All right. So bear with me a little bit. I tend to have a loud voice without a microphone. So if you feel like I'm yelling at you, just tell me to tone it down a notch and I shall. So as Maggie alluded to, and we noted, upper extremity propulsion has been well studied in the literature, both in terms of axle position as well as push stroke patterns. In fact, several upper extremity push stroke patterns have been identified, and you can see up there. Their biomechanics have been evaluated, and that semicircular pattern up here that you see, where you contact, push, release, and come back, has been deemed to be the most efficient for upper extremity propulsion. It's also been shown that a more forward axle placement can place less biomechanical load on the upper extremities during propulsion and lead to improved functional outcomes. However, although it's generally considered to be a more challenging technique than bilateral upper extremity propulsion, no research has been conducted evaluating the effects of either rear wheel axle position or manual wheelchair frame type when using a hemi-propulsion strategy. There has been research in investigating propulsion direction, so either forward or backward. And it's been shown that the backward direction of propulsion is preferred if you're doing high rolling resistance activities. So going, rolling over plush carpet, going up an incline, whereas the forward direction is the preferred direction if you are just rolling over low rolling resistance activities such as firm, level, indoor flooring, things like that. But again, research has not been conducted examining the effect of rear wheel axle position. So again, that K4 non-adjustable rearward axle, or the K5 fully adjustable axle, or frame type, folding versus rigid, for individuals who use a hemi-propulsion strategy. Since literature suggests this technique is inherently more challenging than bilateral upper extremity propulsion, understanding the effects of axle position and frame type is critical in assuring proper recommendations that maximize independence and life participation for these individuals. So now we've talked about the general background that led up to the study and this pilot project. So what were our specific objectives? Well, the primary purpose was to evaluate if using an ultra lightweight wheelchair with an adjustable forward axle position in comparison to a lightweight wheelchair with a rearward non-adjustable axle position would improve independence with manual wheelchair mobility skills and reduce exertion for individuals with BI using a hemi-propulsion technique. A secondary objective was to evaluate if using that rigid frame versus a lightweight frame, both in the ultra lightweight category, can improve efficiency when hemi-propelling. So who did we study? Well, we included individuals with brain injury who were between 18 and 80 years old, were English speaking, used a manual wheelchair for at least 4 hours a day with a hemi-propulsion technique, and who could independently propel their manual wheelchair at least 10 meters. In addition, they needed to have adequate range of motion and body measurements to achieve optimal wheelchair setup for hemi-propulsion in the chairs that we had available for our study. They also needed to have adequate cognition to independently participate in the selected measures that we used as outcomes. So the design of the study was a randomized crossover design using 3 different wheelchairs. First, we had a folding frame lightweight wheelchair, again, without the adjustable axle, and we used the Invacare 9000 SL, which is a commonly prescribed lightweight wheelchair here in the US. We also used an ultra lightweight folding frame wheelchair that has a fully adjustable axle housing that we set at 2.5 inches forward just to reduce the variability, although it can be adjusted anywhere. And then we used a rigid frame, ultra lightweight wheelchair, again, fully adjustable axle, but we set it at 2.5 inches forward of rear. And you can see this one does have those flip up foot plates to allow someone to use their foot when propelling. So for manual wheelchair configuration, how we set these chairs up. Did it not advance? There we go. Our goal was to maintain the same wheelchair configuration over the 3 chairs. So we wanted a seat slope of 0 degrees, a seat to floor height that allowed the hips and knees to be at 90 degrees with a shoed foot flat on the floor, a standard 2-inch foam cushion with a solid seat insert, a seat to back support angle that we set for each participant, like on their first day, and then kept that angle consistent throughout the 2 other chairs they tried. And then again, for the ultra lightweight wheelchairs, the axle was set to 2.5 inches forward of rear. A little bit more about study design. We had an N of 18, and these were enrolled from a convenient sample, as they were either inpatients, outpatients at Craig, or were involved in a community wellness program at Craig. All of the eligibility screening was done by a PT, including range of motion screening, body measurements, so including hip width, thigh depth, and then the heel to popliteal fossa with the shoe on. Each participant evaluated the 3 wheelchair configurations, so the lightweight folding, ultra lightweight folding, ultra lightweight rigid. And each configuration was completed in 1 session, and then all 3 sessions were completed within a 2-week time period. Okay. Sorry, Maggie.
All right, so next we'll go into the outcomes that we analyzed. Since our primary objective was to evaluate the efficacy of the wheelchair configuration, we utilized a modified wheelchair skills test. So the original wheelchair skills test of 32 items, we used a modified version that had been used by Charbonneau in a previous study with individuals with stroke. And in this, we evaluated the raw score, so the sum of the scores that they completed, a goal attainment score, which was the number of items that they were able to pass divided by our goal of them completing all 9 items in that modified version. And then we also evaluated subset scores for high rolling resistance and low rolling resistance items, and we'll go into a little bit more detail about those. Secondary outcomes, we evaluated the wheelchair propulsion test. So this is a 10-meter push test in which we categorize like how they're pushing, as well as gives an idea of efficiency by timing and counting number of propulsive cycles. And then we completed a longer distance 100-meter push test, and we evaluated heart rate both before and after to develop the change in heart rate, and then ask the participant to rate their perceived exertion upon completion of that 100-meter push test. All right, so a little bit more information about our modified wheelchair skills test. As noted, this was our primary outcome. The original test has that 32 skills, and we use that abbreviated version. Scoring on this is completed so that an individual scores 2 points if they pass an item, 1 point if they pass with difficulty, and all of those items of pass with difficulty are like outlined on what categorizes it as a pass with difficulty. Not all items can score a 1, and then a 0 if an individual is unable to complete that task. And to note from our protocol, we provided our participants with cognitive deficits and behavioral challenges about 30 seconds to complete a task before we would score them as a 0. And then we would also provide the verbal instructions as outlined by the wheelchair skills test manual, and then tell an individual that they were allowed to complete the task going forwards or backwards, but we would not cue them to go any specific direction. All right, so next we're going into what our low rolling resistance skills are. All right, so the first one is rolling across a 5-degree side slope. The starting position for this is with a downhill wheel 10 centimeters from a chalked line. An individual scores a pass if they traverse a 2-meter period without drifting below that chalked line. They must complete this going both directions, and this item is scored as a pass or fail only. Next is descending a low curb. The starting position for this is with all 4 wheels on the curb, and the individual is asked to get the chair down the curb. Pass is scored if they're able to safely get the wheelchair off of the curb, so all wheels are on that lower level and they're able to maneuver the chair away from the curb. And a fail is if they're unable to descend that curb safely. This one is also pass-fail only. Next is rolls forward 10 meters. We did this in conjunction with the wheelchair propulsion test. The start position is 2 meters before, and then the ending position is 2 meters after, so judging that middle 10 meters. and scoring a 2 if an individual is able to traverse that distance, which was an inclusion criteria for us. So all of our participants were able to complete that. A pass with difficulty is awarded for this if the subject takes more than 30 seconds or there's significant contact of the anti-tips, and then a fail if they're unable to complete. And then the last of the low rolling resistance skills is turning 90 degrees. So in this one, someone's positioned 1/2 meter from the wall and they are asked to maneuver around a corner. And this is completed again in both directions, and a pass is if they can complete it in both directions, and a fail if they're unable to turn the corner. This again is a pass fail only task. And then we'll go into our high rolling resistance items. This included ascending a 5-degree incline. In this, they're instructed that they cannot use a rail. A pass is awarded if they're able to ascend the ramp independently. A pass with difficulty is awarded if they have significant exertion or a lot of contact with their anti-tips. And then a fail if they cannot ascend from the bottom to the top of the ramp. Next is rolling 2 meters on a soft surface, so using plush carpet. The distance that they're asked to roll across is 2 meters. And this again, pass if they're able to complete that. This one is also pass fail only. Next is getting over a gap. So that's down there on the left. So the gap is the 5-centimeter curb, and then there's a 15-centimeter distance in between them, and then at least the width of the wheelchair. And an individual is asked to traverse that gap. Pass is awarded if they're able to. This one you can score a pass with difficulty if you have loss of control or they say hyperflexion of lower limb. Next is getting over the threshold. So the threshold is 2 centimeters in height, and they're awarded a pass if they're able to get over the threshold. A pass with difficulty, again, if they have loss of control or jarring of the wheelchair or hyperflexion of the lower limb. And like this individual, he made the decision to first try it forward, and then without cueing, he then turned his chair around to try it in the reverse direction. And then the last one is ascending a low curb. So again, this is a 5-centimeter curb, and an individual is awarded a 2 if they're able to ascend the curb, a pass with difficulty if there's jarring due to a sudden stop, or a fail if they're unable to ascend the curb. And we actually did have a couple of people who were able to ascend a curb using hemi-propulsion technique. So it's pretty impressive. This gentleman was not one of them. All right, and then going into our secondary outcomes, as we mentioned, the wheelchair propulsion test was one of our secondary outcomes, and this is what gives kind of the efficiency of propulsion over that distance, as well as some descriptive factors. So we look at this individual, and if they're first, if they're able to complete that 10-meter distance, yes or no, noting the direction of travel, either forward or backward. And then we note what limbs they're using for propulsion. So if they're using a hand or a foot for propulsion, steering, or braking, and then noting what we're using to track how many cycles. So for hemi-propulsion, it's generally the lower extremity that's used to track how many cycles. So this is then timed, and then we count how many propulsive cycles they have over that 10 meters in order to calculate how efficient they are over that distance. Also noting if they are using their upper extremity, if they make initial contact behind top dead center of the wheel, and then during that contact phase, and then during recovery phase, if their extremity drops below that hand rim. If they are using their lower extremity, if they are going in a forward direction, if it's less than 90 degrees that their lower extremity starts in and then ends in greater than 90 degrees, or if they're going backwards, reverse of that. And then our last outcomes were the 100-meter push test. This was a time test over smooth level terrain, recommended to have at least 25 meters before a turn. We were able to complete ours always in the same location where we just had 2 turns. And then we evaluated their rate of perceived exertion using the modified Borg after the completion of that 100 meters, and then evaluated their heart rate both before and after to get the change in heart rate.
Okay, so now you know why we did the study, who we studied, what we studied, and how we studied it. So now let's talk about what we thought might happen. So we hypothesized that individuals with BI using a hemipropulsion technique would demonstrate improved mobility skills when using the ultra lightweight wheelchair with the forward axle position. And again, we use that wheelchair skills test with the low and high rolling resistance skills to evaluate their mobility. We thought that they would demonstrate decreased exertion when using an ultra lightweight wheelchair with a forward axle position. And again, we used exertion was evaluated with RPE and change in heart rate after that 100-meter push test. And then we also thought that they would demonstrate improved efficiency during that wheelchair propulsion test that Maggie just described, using a rigid frame wheelchair as compared with a folding frame wheelchair. Okay, so those were hypotheses. What did we actually find during the pilot study? As far as demographics go, the 18 subjects had an average age of close to 40 years old. The median time since injury was about 20 weeks, and most were male with right-sided brain injuries using the left side for propulsion. Down to the nitty-gritty. Okay, now we have a lot of tables, but I will talk you through them. So for the wheelchair skills test, which again was evaluating independence with everyday wheelchair skills. This table shows there was a statistical difference noted among the 3 chairs. It doesn't say exactly what that difference was, but just there was a difference among the 3 chairs. And this was true for the total raw score, shown there in green, for the low rolling resistance subscore, shown in purple up there, and for the goal attainment score, shown in orange. In fact, if you're just kind of looking at numbers and comparing the ultra lightweight rigid and the lightweight wheelchair, we noted a nearly 1.5 point increase in total raw score, and then an approximate 1 point difference in the low rolling resistance subset score items, and almost a 7.5% difference in goal attainment score. Now this table, this one here, is again showing a difference was seen among the 3 chairs during the wheelchair skills test. However, in order to directly compare each chair to the other, you have to do a multiple pairwise comparison. And so therefore, we need to adjust the p-value using a Bonfieri correction for those multiple pairwise comparisons. When we do this, the threshold for significance drops from that like usual 0.05 down to 0.0167. So following that adjustment, when we perform pairwise comparisons, these reached a statistical significance for the low rolling resistance, again, looking up there in purple, for the low rolling resistance when comparing the ultra lightweight rigid to lightweight folding wheelchair, and when comparing the ultra lightweight folding and the lightweight folding. So both K5, if you're here in the States, both K5 wheelchairs in comparison to the K4 non-adjustable axle wheelchair scored better in the low rolling resistance items. And then there was also significance when for the total score up there shown in green, comparing the ultra lightweight folding to the lightweight folding. What about the wheelchair propulsion test? So again, that was that 10-meter test. And here, no differences were seen in either push speed, frequency, or effectiveness over the 10 meters during this wheelchair propulsion test. And this was true when comparing just among the 3 chairs, and also when performing pairwise comparisons. In fact, participants really had no difficulty traversing that 10-meter path. And as Maggie alluded to, if you remember, part of the inclusion criteria was they had to be able to independently go 10 meters to be part of the study. So what we don't know is, would more differences come to light had we evaluated this over a longer distance, like that 100-meter, had we tried to count push strokes and all of that over a longer distance? We don't know. But speaking of the 100-meter push test, when evaluating exertion, participants demonstrated a higher RPE, so they reported more effort, a longer time to complete the 100 meters, and a larger change in heart rate during the 100-meter push test when using the lightweight wheelchair with the non-adjustable axle, as compared with the ultra lightweight wheelchairs with the forward axle position. So raw values say all of that. When we do the pairwise comparison and do that correction, we can see only that rigid frame ultra lightweight wheelchair achieved statistical significance for all the measures, but it did achieve statistical significance in all of those. So those were a lot of tables, I think 6 of them. So the recap, what did we just say? So there, during the pilot study, again, there were 18 participants with brain injury. There was a statistically significant difference among the chairs for all outcomes, except the high rolling resistance skills and that wheelchair propulsion test. When performing the multiple pairwise comparisons during the wheelchair skills test, there was a statistically significant higher total score for the K5 folding chair with the forward axle over the K4 chair with the non-adjustable axle. A statistically significant higher score during low rolling resistance items for both the K5 folding and rigid chairs with the forward axle over the K4 chair with the non-adjustable rearward axle. And then when performing the multiple pairwise comparisons during the 100-meter push test, there was a lower time to complete, a lower rate of perceived exertion, and a smaller change in heart rate for the K5 rigid chair with the forward axle placement as compared to the K4 chair with a non-adjustable, that lightweight chair with a non-adjustable axle.
All right, so now we'll go into some of the things that we learned and aims for the future. So one of the challenges was the variability in individuals' cognitive status. So we completed 3 separate sessions. They were over a 2-week period of time. A number of our participants were inpatient individuals with brain injury who were changing very quickly. And it was hard to ascertain was it truly the change in the chair and the axle position and the frame type that made the difference in an individual's ability to complete a task? Or was it their cognitive ability to problem solve how to complete a task? And they were randomized. So with a large sample size, that should hopefully wash out, but definitely was in the forefront of what we were thinking throughout the study. So in the future, either figuring out our cognitive inclusion criteria was just that they were able to independently follow our commands in order to participate in the task. Would there be some other sort of evaluation of what their problem solving capabilities were at that point in time to kind of categorize where they were within their injury? And then we also had people who were living in the community, so the variability within that. Next would be wheelchair experience. So again, individuals were anywhere from newly injured inpatient individuals to outpatients to people who were in the community. And their experience in their time spent in the chair. So were they a week from their injury, and that's the only amount of time that they'd had in that chair? Were they a year from their injury? And also, depending on what their prognosis was, for them to be included in the study, they needed to be using the wheelchair with the hemi-propulsion technique for at least 4 hours a day. But that might not have been what they were focusing on in their therapies. So they may not have been trained in a lot of these skills. They might prognostically be inclined to work more on the ambulation aspect and not really get wheelchair skills training. So for future studies, either making sure that we have a large enough sample size. Our sample size here was only 18 to begin with this pilot study, or to only use individuals who are more expert wheelchair users, or stratify. And then outcome measures. So although the modified wheelchair skills test has been used in other studies to evaluate individuals using a hemi-propulsion technique, I, as a therapist, have never tried to teach someone how to ascend a curb using a hemi-propulsion technique. So is that the best tool of evaluation of frame design? Or are there other evaluations that could be used? And I think we did see some differences, particularly in the rigid frame in comparison to the folding frame on an individual's exertion levels and their, like the RPE, the change in heart rate, their speed. And that was one snapshot in time. But I think something that we're really interested in is what is the cumulative effect of that? So what is their exertion level if they're using that chair for the whole day? What about the whole week? So taking some measures and being able to really evaluate that over a longer period of time to delineate what effect that can have in their life. And then one of our last limitations, which we knew going into this based on the differences that we're looking at a ultra lightweight compared to a lightweight chair and the differences between a K4 and a K5 and the adjustability, is that we were intending to be consistent across all the chairs. Our goal initially was to try to use that 2-inch foam cushion, the solid seat insert, to have the floor to seat height so that they were at that 90-90 with their shoed foot. To use a 24-inch rear wheel and a 4-inch caster. Obviously, that is not feasible. And it didn't happen for any of our participants. There was always variability within the wheelchair configuration. So although I think that's a limitation of the study design, that like we noted what the wheel size was, what the caster size was, and then some of the deviations that we had, for example, here, regarding if someone had a shorter lower leg length, then we often had to make modifications for that K4 or lightweight wheelchair for your cushion height because we couldn't achieve the floor to seat height that would allow someone to get that flat foot contact. And that's a limitation in the study as well as a limitation in the difference between that lightweight and ultra lightweight wheelchair. So for the future, if we're really comparing if we're wanting to keep everything consistent, only including individuals who either fit within that category for lower leg length of the K4, or being able to say it's okay that, and there are differences within the wheelchair configuration. Exciting for us that this study we've been accepted to be published in the Archives of Physical Medicine and Rehabilitation. So keep your eyes out for that. And then just wanting to thank Permobile for funding this study and then providing the ultra lightweight wheelchairs, as well as Craig Hospital for providing the lightweight wheelchairs and helping us process this. So